So we are starting our IC and it's on Eyes of Tomorrow. What are the advancements in pediatric ophthalmology? And we are privileged to have Dr. Sheila Nambudri, the famous pediatric genetist, who will be talking to us about the basics of when to refer a patient and what are the associations we have. And very commonly we have doubts as to whether to send the patient for genetic screening. So madam will highlight on all these things. And as all of you know, madam is a pediatric genetist working at Amrita Institute. So you have the CV of Madam. Madam has numerous international and national publications and fellowships from distinguished institutes, and she's the co-chair of ICMR Rare Disease National Consortium Expert Committee. Over to you, Madam.
A very good morning to you all. At the outset, I would like to thank Dr. Meena for giving me this opportunity to address you all. So, coming to our topic, wish you all warm greetings from Amrita Institute of Medical Sciences, Cochin. So, I thought that rather than giving a didactic lecture, it is better to take you through some of the scenarios where the investigations, the genetic investigations have been useful in. Okay. So that it will be, you can relate to these situations in a better way. So this is the blood sample of a 3-day-old baby. You can see that this blood is purely white in color. So when the sample was taken for some other thing because the child was having hypoglycemia. So the triglycerides was 8,800, total cholesterol 592, and VLDL was 374. And the baby was having very florid lipemia retinalis. Actually, some of the slides I have shown to some other presentations also. That is why I have given a normal, which is not at all needed for you people. So coming to this, so what this child was having is a lipoprotein lipase deficiency. This in lipoprotein lipase deficiency, as you think, it is not a very rare condition. We have around 24 patients with proven lipoprotein lipase deficiency. This can be due to two reasons. One is a deficiency of lipoprotein lipase enzyme, or there can be deficiency of a cofactor ApoC2 or ApoA5, which is needed for the proper functioning of the lipoprotein lipase. And this hydrolyzes the triglycerides in chylomicrons and VLDL. That is the reason why the VLDL is also elevated along with the cholesterol and triglycerides. So how do they present? Usually, like this, accidentally only it is being diagnosed, because when you take blood for some other reasons, you will see the white blood. Or if it has not been diagnosed at that point, these children might be presenting with abdominal pain with hepatosplenomegaly. While evaluating for hepatosplenomegaly, you will see an elevated, very, very high levels of triglycerides, and that is how you make a diagnosis. So once they have the triglycerides beyond the level of 1000, they will be presenting with lipemia retinalis and eruptive xanthomas. And the dangerous thing is that these patients will be presenting with very, very severe multiple episodes of recurrent pancreatitis once the levels are more than 2000. So the mainstay of treatment is not any medication, it is a fat restricted diet what is given. So if a baby is diagnosed in a very in the newborn period itself, we will try to reduce the breast milk, and in some of the cases where the levels are skyrocketing, some patients had more than 37,000. So in those patients we will stop the breast milk, and they will be put on a fat-free formula which is very easily available in the market, which is being used for people with high cholesterol levels. And we will also add medium chain triglycerides into feeds, because this will directly get absorbed into portal circulation, and it will not form the chylomicrons. That is why we are substituting it with, because we can't stop all the fat formula from the diet. And once in every 3 months, we will be monitoring these babies, and then early weaning and with complex carbohydrates is the mode what we follow. So here I just wanted to show you that you can see that the levels were even more than 30,000 for at least 4 patients. In one of the patients, it was 38,000 at 3 days, 4 days. So you can see that it has come back so beautifully after modification of the diet. We have not given any particular medication for any of these 24 patients, and this is the response to the diet. You can see that the blood color has become completely normal and the fundus has also normalized. And this is one of the publications what we have written after seeing 15 patients, because this is the diet what we have actually written in detail, because how to modify the diet in these patients. So coming to second scenario, a charge association, charge syndrome. So this is a condition where the patients will be presenting with coloboma of retina or coloboma of the iris, and some patients can even present with anophthalmia. In associated, it is an acronym for the charge is an acronym. So C is for the coloboma, H is for the heart anomalies, and A is for the coronal atresia, growth retardation, mental deficiency, and genital hypoplasia. So these patients have a particular ear. I will show you the picture. So this is called as a typical charge ear. The vertical height of the ear will be very less, and the ear lobule will be very, very tiny. That's a special clue here. So I think as you ophthalmologists, whenever you see patients who are having big coloboma either in the retina or in the iris, it is always better to check for the ears also. So here you can see that the ear lobule is very, very, it is absent here. And some patients can present with microcornea. You can see the microcornea here. And this is the depressor angulae oris muscle deficiency. That's why there is an asymmetric cry. This is otherwise called as asymmetric crying facies, micro penis, and bilateral microcornea. And one of the important clue here is when you think about this condition, they will be having associated semicircular canal deficiency. So what happens is, if it is a big child, you will have to do a CT scan of the temporal bone to see that. But in a newborn baby, what you can do is you can take a lateral X-ray of the skull. So this is the normal lateral X-ray of the skull, where you can see the semicircular canal, where it is completely absent. Here you are not seeing any honeycombing here. So this X-ray is not useful in a bigger patient, but in a newborn child it is useful. So the aplasia of the semicircular canal is very, very classical of this condition. So the triad for charge syndrome is coloboma, coronal atresia, and absence of semicircular canal. If a patient satisfies all the three, so this is almost, it is 100%, it is charge only, and the gene here is CHD7. We have many patients, probably because we have a big number of patients who have been referred from our cardiology setup. So coming to a third scenario, Alagille syndrome. So in this condition, these patients have multi-system involvement of liver, eye, heart, skeleton, and also they also have dysmorphic features. So in liver biopsy, what you see is in more than 90% of the patients, they can have an associated bile duct paucity. 15% of the patients will be presenting with cirrhosis and liver failure. So along with the bile duct paucity, at least 3 of the above features should be there. One is cholestasis. They will be presenting with severe jaundice, cholestatic jaundice, pulmonary stenosis, butterfly vertebrae, which you can identify by taking an X-ray of the chest with abdomen, posterior embryotoxin, and typical facial features. I will show you the picture. You can see that the child is deeply jaundiced, and this is the very broad forehead, and the child is having a very prominent nose and a pointed chin. And this is the father and this is the child. Both of them were having posterior embryotoxin. But the father, apart from having posterior embryotoxin, he did not have any other features. So this is an autosomal dominant disorder, which is having a 50% chance of inheritance. So the point here is that if 2 people are having in the same family itself, they are having the same disease, the severity can be completely different. So the facial feature is prominent forehead, straight nose, bulbous tip, and pointed chin, and inverted triangular face. So this is the father. Actually, the inverted triangular face is very, very clearly seen in the father, and the posterior embryotoxin, which was identified by the slit lamp evaluation for both of them. So the way how to diagnose this condition is by doing a mutation analysis. So this is an autosomal dominant disorder with variable expressivity, as I have told you just now. In around 89% of the patients, you can identify a variation in the JAG1 gene, and in around 7% of the patients, if it is not there, you should think about a microdeletion in chromosome 20, and in very, very tiny percent, around 1% of the patients, they can even have a variation in Notch2 gene. So the next scenario I would like all of you to pay attention to. So this was a 12-year-old boy who had presented with severe burning pain of the dorsum of the hands and feet for past 1 year, and he actually just because he didn't have any other particular physical features, he was considered as a child with any psychological issues, and he was sent for psychological counseling from elsewhere. He did not have any joint involvement, and he also had very severe sweating deficiency, and he was not interested in getting involved into exercise or any other thing. So he also had a small fiber neuropathy when he was evaluated in neurology and was referred to a department. And with all these features, the possibility of Fabry's disease was considered, in his alpha galactosidase was sent, and it was very, very low. So in these patients, they present with angiokeratoma. I will show you a picture. This is the typical angiokeratoma. These are the red small tiny nodules which are seen in the bathing trunk region. So unless you undress the patient, you might completely miss that. And this is the patient. And in angiokeratoma, you need not see this much amount of angiokeratoma. Some of our patients were having only 1 or 2. So angiokeratoma is the cutaneous vascular lesion seen in the bathing trunk region. And these patients usually present with very severe burning, tingling, and numbness. And some patients can go into extreme pain crisis, which is lasting for hours to days. They even need morphine. And the importance in ophthalmology is more than 70 to 90% of the patients will be having a typical cornea verticillata, which is very easy to evaluate. And these patients, they present with 3 ways. One is with stroke, one is with progressive renal failure, and other group of patients will present with hypertrophic cardiomyopathy. So in the same family itself, some patients present with stroke, some present with renal failure. So everybody might not think that everything is related with each other. The beautiful part of that is that and around 70 to 80% have an associated hearing loss. So this is the cornea verticillata which is seen due to accumulation of the sphingolipid in the corneal epithelium. So this is an X-linked disorder. So it can affect males as well as females. Females are mildly affected than males. And the beautiful part of this is that there is a treatment. The enzyme replacement therapy is available. The alpha galactosidase enzyme can be given for the patient once in every 2 weeks. And this will reduce the corneal deposits. It is beneficial for paresthesia. The pain will completely disappear. It will halt the progression of the cardiac disease, stabilizes the renal function, decreases the abdominal cramping, and markedly improves the quality of life. Actually, this patient who was having this much amount of pain, now he has completed his degree and he is going to join for a government job. So another thing is, I think you will be encountering patients with anophthalmy and cryptophthalmos. I don't know whether it's a routine practice for you to send for a genetic analysis, but I think you should always try to send it, because there are mainly 3 genes which are involved. One is SOX2, another one is OTX2, and PAX6. So the advantage is that the couple will be so much apprehensive to go through the next pregnancy. Nowadays it is ultrasound can pick up, but I think still it is very good if you are making the diagnosis, so that we can offer prenatal diagnosis. Another thing is, whenever a child who presents with cataract, we always think about the possibility of congenital rubella syndrome, but if it is a male child, please also consider the possibility of oculocerebrorenal or Lowe syndrome, where the patients will be presenting with congenital cataract with glaucoma. They will be having, the clinical features would be, they will be having congenital severe hypotonia, mental handicap, and the urine should be, the simple way to think about this condition is check the urine. The urine will be having increased proteins, and also amino acid will be excreted through urine. And this is an X-linked recessive disorder. It is extremely important to have this diagnosis so that we can offer prenatal diagnosis. The gene is OCRL, and we can offer, the chance of a woman who is a carrier for Lowe syndrome is 50% for her to have another male child with the same disease. So this is a child with Lowe syndrome with bilateral cataract at birth, and he also had severe glaucoma also, and this is after cataract extraction. But this condition, there is no treatment for this condition. Usually these children will die by 2 years of age. So another thing is cystinosis. We have 2 patients for whom we are treating them with cysteamine. They will present with hypophosphatemic type of rickets with renal fanconi. So the urine will be, there will be urine sugar will be there, and urine proteins will be excreted. They will be presenting with severe photophobia by 1 year of age, and it is a autosomal recessive disorder, and they can be treated with bicarbonate citrate and vitamin D for the hypophosphatemic rickets, but the actual treatment is oral cysteamine. Even the eye drops are also available for controlling the cysteine crystals, and most of them will go ahead with the renal problem, and they would need a renal transplantation. And this is the cysteine crystals in cornea. And retinoblastoma, I need not explain to you for this August crowd. And in retinoblastoma, the parents of the patient with retinoblastoma should be examined for spontaneously regress retinal tumor, and two tests should be done. One is the mutation analysis. In around more than 90% of the families with bilateral or familial retinoblastoma, you can get a mutation, and if it is not there, in around 3% of the patients, FISH analysis is indicated to identify whether there is a 13q deletion. So that can be there in around 3% of the patients. And the most important question what the family would ask is, what is the chance of us to have another affected child? So if the child is having a bilateral retinoblastoma, the chance for the next child to be affected is around 5%. If it is unilateral, it is only 1% for unaffected parents. If one of the parents had retinoblastoma, the risk is 50%. So this is the last scenario. This is a von Hippel-Lindau syndrome. This is an autosomal dominant disorder which is with a defect in the tumor suppressor gene, and around 70% of the patients will die with clear cell renal cell carcinoma. So if a person has been identified, this can affect males and females. If a person has been diagnosed with von Hippel-Lindau disease, the chance of his or her children to be affected is 50%. So if you are not doing the genetic analysis, so the screening of the eyes should be started even for retinal angioma should be started even before 2 years, and urine catecholamine should be done by 2 years for checking for pheochromocytoma, and after 11 years lots of investigation surveillance should be done for MRI brain and ultrasound abdomen and CT scan abdomen once in every 6 months. So these are the renal capillary angiomas in von Hippel-Lindau disease after fluorescent angiogram. So this condition with a typical it's a multi-organ disease: retinal angioma, cerebral hemangioblastoma, spinal hemangioblastoma, liver hemangioma, and the major important thing is the renal cell carcinoma, pheochromocytoma, and cystadenoma of the testis and also the broad ligament. So this is the mural nodule in the left cerebellum what we can see, and this is the clear cell carcinoma and pheochromocytoma. So to sum up, ophthalmic clues are very important handles for clinching the diagnosis for CHARGE syndrome, for Alagille, for Lowe syndrome. The yearly fundus examination is a non-invasive screening modality for von Hippel-Lindau disease and also for neurofibromatosis type 1. Slit lamp study is extremely useful for detection of Fabry's disease, for which there is a definitive treatment. I thank Dr. Natasha and Dr. Rehana for providing me with various slides from ophthalmology, and thank you all.
Thank you, Dr. Sheila Nambudri, for this very exhaustive presentation. And for the benefit of all of us here and all the audience, I would like to know where exactly can you do this genetic analysis, and how frequently it is done, and what is the expense involved?
Thank you, ma'am. Nowadays lots of private labs are doing all these tests. Previously we have been doing a test called clinical exome where only 8,000 genes are studied. So it has been identified that in human beings somewhere around more than 25,000 to 26,000 genes are already identified which are associated with a particular type of disorder. So what we can send is a whole exome sequencing for these patients. The charge of this test will be somewhere around 17 to 18,000.
Gene therapy being done?
No gene therapy. Actually, I wanted to ask you whether there is any gene therapy for because patients come to us for mainly with retinitis pigmentosa. But in between I have read that it is available. Whether it is available, I just wanted to know whether treatment is available for it. The only condition for which the treatment is available is now is for spinal muscular atrophy or SMA, as you all know, which is extremely costly, 17 crores. And for Duchenne muscular dystrophy also, it is a little bit therapy is coming. But I think for RP it is not available yet, no? Okay.
Only literature says so.
Okay.
It's not available.
Madam, kindly accept this token of appreciation from KSOS and from us.
Now I request Dr. Meena CK to present her talk on advances in amblyopia management. Amblyopia has come a long way. Dr. Meena is a very renowned pediatric ophthalmologist, strabismus surgeon, and a phaco surgeon. Over to you, Dr. Meena.
Thank you, madam. I'll be speaking on advances in amblyopia management. There has been so many overlaps. Even yesterday we had so many talks on this, and I have no financial disclosures here. And as all of us know, amblyopia definition, like the physician sees nothing wrong for the reduced vision, and also the patient doesn't see well. And the current treatment options we have are patching and penalization. Of this, mainly we depend on patching. And as all of us know, patching is a very good form of therapy, and it does give improvements. But only thing doing it is usually they don't stick to the treatment protocols and regimes. So why do we need a change from patching? So there has been a paradigm shift in how the etiology of amblyopia is being viewed. Like we always, whenever we do patching, we are just closing one eye. So this is like, it has been now considered to be a binocular problem. So structurally you have an intact binocular system which is rendered functionally monocular due to the suppression, and also whenever you are doing the patching, you are covering the good eye is not at all working. So now all the treatment regimes, most of the treatment regimes are based on using both the eyes. So what are the replacement for patching and penalization? So you should know two terms mainly, that is the perceptual learning and the dichoptic therapy. So perceptual learning has a very complicated definition, but basically what you should know is practice makes perfect. So you do the same thing repeatedly to make it perfect. So you have monocular as well as binocular perceptual learning, but more importance have been given in the reason for the newer treatments for binocular perceptual learning, where you involve or use both the eyes. And here comes the dichoptic therapy, where both eyes are being used and each eye is exposed to similar but slightly altered stimuli, and they are presented simultaneously. It is just like what we were using in the synaptophore earlier, which we are not using much today, but this is being used with the help of devices. So how do you do it? Like there are different methods of how to differentiate the two images. Like you can change the contrast. Like one good eye you give low contrast, and the amblyopic eye you give higher contrast, or a visual blur, like the image is blurred in the better eye, and also partial presentation, like you had a rabbit and a tail in synaptophore, you give incomplete images in two eyes and you have to fuse it, only then you will see it as a proper image. So how do you give all these, like it has to be more interesting, especially because children are involved. So how do you provide all these images? Like you have these interactive video games, then virtual reality and augmented reality devices are the, has been given so much importance nowadays, and you can even have passive dichoptic movie, that is just sit and watch a movie, but you have to use both the eyes to get a proper view of the movie. And so much has been talked about vision therapy, because nowadays it seems like it's just, your aim is not to improve the number of lines of vision, but it also to improve your binocularity, your stereopsis, etc., and transcranial electric stimulation, of which we have no experience. So we'll go into a few of which that is available in the market, and I have no financial disclosure. We do use one, and here you can see that this is the vision therapy, where you can see dissimilar images in both the eyes. Like you can change the contrast of the image, you can change the brightness, or you can dim it. So there are usually the weaker eye is given a better image, and the basic principle is you have to use the weaker eye to get a product. Like if you have a game or something has to happen in that device, you have to use the weaker eye. So here you can see that you can change the contrast, the colors, everything in the video. Now this is the virtual reality or the augmented reality ones, Luminopia, which is FDA approved, and here again you can see that the child has to use the goggles, the virtual reality goggles, and you can see the reduced contrast in the better eye, and you have a dichoptic masking. That is, you have to see the proper image, you have to use both the eyes. And even they can watch movies or videos with the help of these virtual reality goggles. So it helps to keep their interest, and it is FDA approved also. And this is something like passive, as I mentioned earlier, you have passive dichoptic movie viewing. That is, the image, the importance of this thing is you have a pupil tracker. So most of these cases you have to use red blue or red green goggles, and here you can see that there is, because of the pupil tracker, the center of the good eye is blocked. Like you have a blurring of the central view, but your peripheral vision is still there in the good eye. So your good eye is still working, it's not that's completely blurred. And this blue light in front of the weaker eye is helping to get a proper image, and also so you are using more of your amblyopic eye. Now this is what we have experience with Binox. Like Binox vision therapy, again here the background is same, but the foreground is little different. That is, here again you are using the red and blue goggles, and the blue, the weaker eye only is has to act to bring about some action, like this blue car chasing the petrol bunks. So it has to be used. So that is the basic to keep the interest of the child. So most of these are games. And Revital Vision is yet another FDA approved one, and here they say it improves even adult amblyopia, and GABA patches are being used here. That is contrast, they can be changed, like the contrast as well as the, you can see the patches here, the GABA patches. And orthoptics, which has been invented by our own ophthalmologist, where it's something like a field test, where you have to spot the peripheral lights, you have to count the peripheral lights with each eye, and also binocularly, which has been developed by Dr. Santam Kobal, an ophthalmologist. So the major problems are the cost of these devices, and also you have to, the home therapy might be easy, but I don't know if they do it properly. So some amount of office therapy you have to start with, and in severe amblyopia we have seen that it's not that easy. Though you have medical therapy, we are not using it much, and the main problem with this perceptual learning is the boredom and the time factor, but still it is excellent. When compared to patching, I think more interest for the children will come for these type of treatment, and hope we will come up with more devices soon. Thank you.
Thank you, madam. Thank you, Meena madam, for the excellent talk. Now I invite Elizabeth madam for her talk on true muscle transplantation in large angle strabismus. Madam does not need any introduction. Her name itself is enough. Welcome, madam, for your talk on true muscle transplantation. Over to you, madam.
Thank you, Dr. Meena, Dr. Arun. Good morning, everyone. This is a new procedure in strabismus, muscle transplantation in large angle deviations. See, muscle transplantation is a surgical procedure which involves suturing the resected autograft of the rectus muscle to the disinserted end of the opposite rectus muscle. In the diagram, you can see that a piece of the medial rectus is brought towards the lateral rectus and sutured. So that is the muscle transplantation. By doing this transplantation, we lengthen the muscle, and by further recessing this elongated muscle will produce further weakening. This surgery is used to correct large deviations. Indications are large deviations, especially sensory exotropias or esotropias with dense amblyopia, where patient is reluctant to operate the only seeing eye. It's not useful in paralytic squints or restrictive squints. See, this is a child with a very large ESO deviation with amblyopia in the left eye. Here, the goal of surgery will be to achieve a satisfactory motor alignment with no postoperative limitation of ocular movements, no induced lateral incompetence, no diplopia, and there should not be any enophthalmos, and we should have a good long-term result. That is our aim. And our options for large deviations right now is either supramaximal recess resect procedure. Supramaximal recess resect procedure will produce lateral incompetence and defective ocular movements. Then the other option is more than 3 muscle surgery. There, with the 3 or 4 muscle surgery, you can correct this large squint, but the patient will be usually reluctant to operate on the only seeing eye, the other eye being amblyopic. And hemi hangback procedure is another procedure, and the muscle transplantation is the latest one. I have put in some review literature about supramaximal surgery. They say that supramaximal surgery will produce more lateral incompetence and enophthalmos. And hemi hangback procedure have got the problem that the muscle may creep forwards and it may result in defective motility. And more than 3 or 4 muscle surgery is like this. You can achieve orthotropia, but you have to operate on the only seeing eye also. So here comes the importance of muscle transplantation, which improve the effective length. Chances of rejection of the muscle are none because it's an autograft, and since the position of the muscle is anterior to the equator, there is no limitation of extraocular movement. This is the child who underwent transplantation. You can see the video. So that's an esotropia. We are planning recession of the here, we are planning a resection of the lateral rectus and recession of the medial rectus. Now the lateral rectus muscle is hooked, and we are planning a 6 millimeter resection. So sutures are passed 6 millimeters behind the insertion, and the entire width of the muscle is woven by this suture. I use a 60 vicryl suture, and the sutures are locked in itself so that the entire muscle is kept in your suture. By applying this, after applying this suture, the suture ends are secured in a clamp, and then another suture is applied 1 millimeters behind the original suture, and in between these two sutures we are planning to cut the muscle. And after securing the suture ends, we go to the site of insertion. At the site of insertion also we put a pre-placed suture, so that we want a small segment of the muscle with 2 sutures on either side. After applying the suture, the muscle is cut. The segment of the muscle is cut like this, so that you get a 6 millimeter stump of the muscle. You can the muscle piece is cut at both ends, so that you get a 6 millimeter block of the muscle with sutures on either side. That way we retrieve a piece of the muscle, and then that muscle piece is kept securely in balanced salt solution. Then the resection of the muscle is completed by pulling the muscle anteriorly and fixing it close to the insertion. Then I close the conjunctiva with the glue. Nowadays we don't do any suturing of the conjunctiva. We do fibrin glue sorry, to close the conjunctiva. And now we have done a resection of the lateral rectus, and we have a piece of the lateral rectus that is transferred to the medial rectus. The medial rectus muscle is hooked, and the piece of the lateral rectus is sutured at the insertion of the medial rectus first. I usually use only synthetic absorbable sutures, but there are surgeons who use non-absorbable sutures. Our sutures with this kind of sutures, 60 vicryl sutures, will dissolve only by 6 weeks, and by that time the muscle would have taken up. This you can see the muscle being grafted to the edge of the medial rectus muscle. This new stump of the muscle is an autograft. It will not have the contractile property, but it will act as a fibrous tissue later. Then now the lengthened muscle is recessed. You can see the medial rectus muscle is recessed by 7 millimeters. So we have a 7 millimeters recession with a 6 millimeter elongation that will give rise to about 13 millimeters of weakening. That will produce a huge medial rectus weakening, but since the medial rectus is still anterior to the equator, it will not produce any limitation of movement. You can see the postoperative picture. This is the first postoperative. Eye is orthotropic and movements are normal. And this is the late postoperative picture taken 2 months after. Compare it with the preoperative picture. The patient is orthotropic with only one eye surgery and movements are full. And coming to the review of literature, I have put in two reviews. One is by Amitava et al. Here he has said that this will not produce any limitation of movement. Another by Jitendra Jatani, and he also says that surgical results are stable. So this is a good procedure. To conclude, unilateral recess resect procedure with muscle transplant is superior to unilateral supramaximal surgery. This will produce better cosmesis, no lid fissure changes, no lateral concomitants. You can get primary position orthotropia. You can limit surgery to one eye, less traumatic and especially useful in large deviations with dense amblyopia. Thank you.
Thank you, madam, for this wonderful talk and very clear videos. Now we will go on to the next speaker, Dr. Arunlal JS. He is from Little Flower Hospital, Angamali, and he will be talking on evolving perspectives, low dose atropine and beyond.
Good morning all. Thank you, madam, for this opportunity. I'll be talking on low dose atropine in myopia. As we know, myopia is a global epidemic. 50% of the children in the world is estimated to have myopia by 2050. So early intervention can slow down or prevent myopia progression to a meaningful level. So these are the risk factors of myopia progression. And currently we have these peripheral correcting lenses, different type of lenses and spectacles, orthokeratology, atropine and environmental modifications are the treatment options we have now. Among that, atropine is the most commonly used method of myopia control. I shall discuss what is it, how does it work, what are the evidences we have for the use of atropine, and why atropine is preferred over other treatment modalities, and at last a guide to clinical practice. What is it? It is available as 0.01% and is found to be effective in Indian children. How does it work? Animal studies have shown that atropine acts not through blocking accommodation but in a different pathway. Actually, the eyeball growth is not controlled from the brain or brainstem or anywhere, but it is said that it is controlled from the peripheral retina. Actually, what happens is, in the peripheral retina, the L and M cone cells sense the focus of the peripheral rays, whether it is in the myopic side or whether it is in the hyperopic side, depending upon the focus of the peripheral rays. These L and M cones send signal to the RP and choroid, and that will lead to remodeling of sclera in the desired way, towards the myopic side or towards hyperopic side. So this action is thought to be mediated through the muscarinic receptors. So what happens in myopia is, since we use myopic glasses, it will lead to peripheral hyperopic defocus. So these cells send signals to the sclera in such a way to enlarge, so that when the sclera enlarges, there will be decreased production of collagen that lead to sparser and smaller content of collagen in the sclera that lead to thinner and weaker sclera. Since it is mediated through the muscarinic receptors, when we give atropine, it will block the muscarinic receptors. In that way, that will slow down the growth of the eyeball. But as a part of the side effect, since it blocks the accommodation, there will be photophobia and blurring of vision. But the thing is that now it is said that it does not work through this muscarinic receptor blocker, but through a different pathway. What is it? It releases the dopamine in the extracellular matrix and vitreous, and that dopamine will inhibit the signaling process. Hence, it will inhibit axial elongation. It also increases the choroidal perfusion and modifies scleral fibroblasts in such a way to inhibit the axial elongation. So these are the side effects. But the systemic side effects are very rare with low-dose atropine. Now we shall see what does we have for the use and efficacy of atropine in myopia progression. We have ATOM 1, ATOM 2 and LAM studies. The ATOM 1 study was done in Singapore between 1994 to 2004 in children aged between 6 to 12 years. They compared the efficacy of atropine 1% with the placebo. At the end of 2 years, what they observed is there is huge difference in the refractive change with 1% atropine at the end of 2 years. At the end of 2 years, they stopped atropine and did not use any drug for the 1 year. That is the washout period. But at the end of 3 years, that is in the washout period, what they found that even with atropine 1%, we got a huge effect within the first 2 years, but there was greater rebound. So, in conclusion, atropine 1% was effective, but there was great rebound with some amount of photophobia and blurring of vision. Then came the ATOM-2 study. In 2006 to 2012, they compared 0.5%, 0.1%, and 0.01% of atropine. And at the end of 2 years, what they found was all of the three drugs have the similar effect. And after the 2 years, they stopped the drug and followed up for 1 more year. But at the end of the 3 year, that is after the end of washout period, what they found was the 0.01% group was not progressing much without any rebound, but the other groups has got significant rebound effect. When we followed up for the 5 year also, this was the same result. So, atropine low dose atropine is effective, but in a dose dependent manner, and the effect is more on the refractive status rather than the axial length change, because in this graph we can see even though the refractive change was significant with all of the 3 drops, but in low dose atropine in the 0.01% group, the axial length change was not much significant. So, atropine 2 concludes, ATOM-2 concludes that long-term effect was better with 0.01% with least side effects, but it has no much effect on the axial length change. Then came the LAM study. In LAM study, they used 0.05%, 0.025%, 0.25%, and 0.01% atropine. They found that there is significant effect with all the 3, but the effect was maximum with 0.05% in terms of refraction change and axial length change. So, in conclusion, 0.05% was the best treatment among all the 3 in terms of refraction change and axial changes without much side effects. Do we have Indian studies? Yes, we have. These are the few Indian studies. Then why atropine is preferred? In this meta-analysis of Hong et al. In 2016, they reviewed different treatment options for myopia. 16 interventions in myopia they compared, and the best effect as seen in the figure, it was with atropine. So, even it can be compared with other modalities of the treatment also. So, do we still have unanswered questions? Yes, we have. Which is better, 0.05% or 0.01% for long-term use? For the time being, atropine 0.01% is the recommended one. What are the indication? Age between 5 to 15 years, increase of myopia of 0.5 diopter or more per year, or axial length change more than 0.1 millimeter per year. But keep in mind, it can only be used in simple myopia, true axial myopia only, not in index or pathological myopia or ROP associated myopia, and we have to follow up every 6 months, at least for 2 years we have to give. When to stop therapy, age more than 14 years, or no progression for at least for 2 years. How to follow up? If you get a good response, continue treatment. Moderate response, you increase the frequency or change to a higher concentration. In non-responders, we can try increase in frequency or try to change to a higher dose, or we can adopt another modality of treatment in the form of optical, or we can combine atropine with the other form of therapy like DIMS or ortho-K. In conclusion, low dose atropine, that is 0.01% atropine, is a well proven treatment option for myopia control. It is relatively cheap, easily available, easy to use, and almost no side effects over long-term use. It can also be combined with the DIMS or ortho-K. But keep in mind, atropine has a dose-dependent effect on axial length and even in refractive change. So, 0.05% may be the future of myopia progression treatment. Thank you.
Thank you, Arun, for the detailed history of atropine. And still we are using the 0.01, still not available 0.05. And also we always check the axial length before starting. And mainly for myopia, not for the astigmatism also, that's what we say. So next we go on to the next speaker. We welcome Dr. Lucy Taliath. She is from Puttalat Eye Hospital, Calicut, and she will be speaking about the glasses which prevent progression of myopia. That is about navigating innovations, peripheral defocus lenses in myopia. Over to you, Dr. Lucy.
Good morning. Thank you, KSOS and Dr. Meena, for giving me this opportunity My topic is peripheral defocus lenses in myopia. So why should we treat all these cases of myopia? As we all know, myopia is on the rise and is expected to affect around 50% of the population, as say so many studies conducted around the world, and the Indian studies also show similar findings. And once we diagnose a case of myopia, our aim should be to decrease its course, and there are various interventions to reduce the progression, and these are the interventions which are shown to have effect on the progression. This is the behavioral intervention, and here we have to increase the time spent outdoors and also decrease the screen time. And the pharmacological treatment has been already dealt with. And next is the optical treatment. And there are various theories on myopia. I'll just tell about various theories. One is the feedback mechanism, one is the contrast theory, mechanical tension theory, accommodation lag theory, and the peripheral refraction theories. And the glasses are mainly based on the peripheral refraction theory. So how does it act? And when we give a single vision glasses, the light focuses on the retina mainly in the central area. And in the peripheral areas, it has a hyperopic defocus mainly. And that is, the light will be focused behind the retina. And this acts as a stimulus for the axial length elongation. And what was it based on? It was based on various animal studies. This is a famous study by Earl Smith et al. And in his studies, he found that the visual signals from the fovea are not essential for the normal refractive development, and peripheral retina in isolation can regulate the emetropizing responses, and peripheral hyperopic defocus is the cause for the progression of myopia. And what does it exactly do? This peripheral hyperopic defocus induces a cascade of cellular and biochemical changes in the retina, causing RPE and the choroidal changes, leading to scleral remodeling and growth, and resulting in the altered ocular growth and the refractive status of the eye. So our glasses and peripheral defocus lenses, what does it do? It converts this hyperopic defocus into a myopic defocus, and thus reducing the progression. And before treating all the cases of myopia, we should know whom not to treat. We should not treat a case of pathological myopia, a syndromic myopia, as those associated with the Stickler-Marfan syndrome, and myopia associated with glaucoma, myopia with prematurity, simple myopic astigmatism, and in a case of compound myopic astigmatism, where the cylinder power is much, much more than the spherical power. So whom should we treat? A simple myopia and a progression recorded more than 0.5 diopter, and an axial length more than 1.1 millimeter recorded over a year, with a strong family history and a young age of onset. So what are the various options available? Spectacle lenses are available in India, is widely used in India, and contact lens is not much used in India. And these are the various options available in India. One is the DIMS glasses, or the defocus incorporated multi-segment spectacle lenses. Next is the HALT glasses, that is the highly aspherical lenslet target spectacle lenses. Next is the lenses using the KI technology, or the cylindrical analog refractive elements technology. I'll just go through the glasses, and all these glasses, peripheral defocus glasses, have a central clear zone for the distance vision, and depending on the type of glasses, the central area will be different. And in DIMS glasses, which is known as the MyoSmart glasses, marketed by the Hoya group, it has a central 9 millimeters clear zone for the distance refractive correction. It is surrounded by like 400 multiple defocus segments, or each of 1.03 millimeters, and this has a plus 3.5 myopic defocus. And what does it do? It produces a simultaneous defocus both during the distance and the near viewing, and thus one plane is created on the retina and one plane is created in front of the retina, creating a myopic defocus, and these are due to the +3 defocus lenslets. And next is the Hall glasses, lenses. It's called the Stellus glasses, marketed by the Essilor group. And here it is 9 millimeter central clear area surrounded by 11 concentric rings of aspherical lenslets. And these lenslets have plus power, and the plus power also varies according to the refractive status and also from the center to the periphery. And it produces a three-dimensional volume of defocus in front of the retina of the varying dioptric power. And next we have the glasses using the CARE technology. Here we have a central, similar to the old glasses, we have the central clear zone for the distant vision, and surrounding it we have alternating cylindrical elements for the defocus part. And it forms a these cylindrical elements forms a caustic as that we get from the when light passes through a glass of water. And this caustic has an extended focus, and this causes a myopic defocus in front of the retina. And this is known as the myopia lenses, marketed by the Zeiss group. Two models available, one for the less than 9 age group and one for the more than 9 age group. And for the less than 9 age group, it is central area is 7 millimeter, and for the more than 9 age group, it is 9 millimeter central clear zone. And the power ranges for the DIMS, HALT, and the CARE technology are shown here. For the DIMS, it's like up to -10 D sphere and up to -4 D cylinder, and the HALT glasses -12 and D sphere and -4 cylinder, and the CARE technology -9 sphere and -6 cylinder power. And about the various journals, we have many studies conducted on these DIMS glasses, and DIMS have the maximum follow-up because it was the first introduced. And in the study, it was conducted in Hong Kong, and myopia has shown to be progress of 52% more slowly in those wearing the DIMS glasses compared to the single vision glass. And also the axial length elongation was less by 62% in the DIMS group. And there are various studies conducted by the DIMS glasses, DIMS, all these defocus glasses, and it's around 60 to 70% slower myopia progression in most of the studies. And on the effect on the visual functions, the long-term study conducted by Lam et al. Showed that the visual function in those wearing the DIMS glasses is similar to that of the single vision glasses. And also there is no evidence of much rebound effect in those wearing the DIMS glasses. And I'll just go through the contact lenses. These are not much available in India, and there are two types. One is the soft contact lenses, which is the daytime wear lens, and the ortho-K lenses, nighttime wear. And this is a table showing all the commercially available contact lenses with peripheral defocus designs. And most of the studies are on the MySight design, which has a multi-zone design contact lens, which has also demonstrated good decreased myopia progression. And ortho-K lenses, as we know, the myopia is by the corneal's flattening mechanism, and also the peripheral rays by the ortho-K lenses it is focused in front of the retina, causing a peripheral myopic defocus and thus decreasing the progression. And it offers around 50% myopia control effect. And so the major concerns in these lenses are at the age of starting the contact lens, the risk of the infections, and the rebound effect. And because of all these and cost factor, these are not widely used in India. So before I'll just say what and all we have to look before dispensing the glasses. We have to select a correct frame. The frame should at least roughly around, it should be from the eyebrow, or else all these segments won't be included in the glasses. And it should be not loose, not tight, and the IPD should be accurately marked, because we have only 7 to 9 millimeter of the central clear area for the distance vision. And also you should tell the parents that to make the children wear the glasses for at least 12 hours, and also not to remove them during the near work. Though there are many optical treatments available, long-term studies comparing the efficacy of each modality in Indian scenarios are necessary for the substantial results. So we have some results from the Indian studies, that is mostly from the combination treatment like DIMS and low-dose atropine. So we need to have Indian studies for that, and always remember, give the parent an option when you record a progression of myopia. All the various options you have to give the patient, and all depending on their comfort, and they can choose. Also, don't forget to tell them about the cost, about the side effects of the if it is the drops, you have to tell them the side effects, and always give them the option. Thank you.
Thank you, Dr. Lucy, for that lovely talk. And we have maybe 3 minutes for discussion. Any questions from the audience? So what are your experience with these glasses?
Ma'am, my first experience is with my daughter alone. That was her photo, ma'am. Actually, it was like I started, like I have my family, there is a family history of myopia. So I've been screening her from like 3 years of age, like from before that also. Like her myopia started at by maybe 5 years. It was just 0.5. Then it was like 0.75. Then at 1, I started with low-dose atropine, but I couldn't manage my child, and then I shifted to peripheral defocus glasses. And the only problem with the glasses I found, it was like when her cylinder power changed, ma'am. So I had to change the glasses. Till now it is like I've been using it for like past 2 years. Till now it is like 1 only, ma'am. Sphere has not changed. And for the patients also, I'm happy with the results till now, except for one patient for her, I had to combine, like I had to start low-dose atropine also, because it was progressing even after the glasses. And also we have to tell the patients that they have to have some modification on their lifestyle also. They have to spend the time outdoors. They should involve in some outdoor activities, and also limit the screen time.
Okay, that is the greatest experience as a mother as well as a clinician.
One more question. And these companies say that they will give free of cost if the refraction changes in 1 year. If the cylinder changes also, will they give you free of cost?
I haven't had a cylinder change, and for my daughter they gave it free, but I don't know like whether they'll give it.
Madam, you mentioned that it cannot be not given in high myopia or pathological myopia. What's the reason behind why it should not be given in a pathological myopia or high myopia?
Even after, like, if you give all this, because it's a different entity, it will progress even if you give all these methods.
Is there any issue if we give it to them? Because these are the target population which come for some or the other sort of solution. Like, how can we reduce their progression?
So maybe after some time the scenario can change. So maybe when you start with, it is just you have certain criteria like how much of progression, 0.5. So pathological myopia, the patient, it could have been a lasered one ROP, post ROP. In such cases, we don't know if it will act. So it's such an expensive one. No contraindication. I don't think there is any contraindication.
That's what I wanted to know, if it's contraindicated.
Even for ROP patients, occasionally we do give atropine. We follow them up, that's all. So there's no danger in giving, but usually we don't give.
I'm asking about the lenses, the peripheral.
I know, I understand.
That we can give to pathological myopia. There is no contraindication.
There is no contraindication for giving, because these lenses are very expensive. That is the main concern actually.
But such children do come to us. Like, what is the solution? Is there any
There's
problem?
no harm in giving, that's all we know, because there's no literature also on that.
Because it was written. And it's mentioned also 9 diopter you can give. So, means at least till that we can really give, no?
But you can give, but always tell the patient it might not be very effective.
Okay,
you can
because
always
it's a
try.
high
It's not
expensive.
contraindicated.
Okay, thank you.
Thank you. ഫസ്റ്റ് ഗ്ലാസ് ആണോ പറയണം ടു ഗിവ്?
Actually, that is a catch. Actually, it's very you can check the peripheral refraction, and you need a experienced refractionist and all for that. So it in typically these myopic eyes, in studies it's shown that it has a hyperopic defocus. So it's more effective in the hyperopic defocus eyes, but it is I don't do peripheral refraction for these cases because of the I give like that. If once progression is recorded, I give.
Thank you everyone for attending this IC, and I thank all the speakers also. Thank you.